meeting which is happening in Delhi at the Bharat Mandapam right now. And we are really honored to have with us Maxine Whittaker. She is a public health leader on One Health, and she's also the civil society representative for the Global Fund Regional Artemisinin Initiative of the Greater Mekong Sub-Region. Thank you, Maxine, for
My
being
pleasure.
here with us. And incidentally, we've had World Malaria Day yesterday only.
We did, yes.
And WHA, that is the World Health Assembly, is going to happen next month in Geneva. And at the same time, we have just 5.5 years left to end malaria as one of the Sustainable Development Goals. Can you please share with us or let us know where are we in our fight to end malaria, where no one is left behind?
Thank you for that question, and a very important one, and a very complex answer because it depends where in the world, the malaria endemic world you are, how close we are, but also some of the shifting sands that are happening at the moment around funding, global health architecture, and even the workforce that's being funded to work on this is making it a little bit hard to predict. My crystal ball is a bit cloudy. So I'll start with the area that I work a lot in the Greater Mekong sub-region. Yes. We have got 3 countries, Vietnam, Laos, Cambodia, that are very close to eliminating. The last kilometre, or as some people hearing at the World Health Summit, if you take a community perspective, the first kilometre, that's really where we still have some work to do. There are innovative ways of trying to work with communities, engaging communities to actually try to find best ways to meet their needs. And so I think in those countries, if we can stay on target and we also get transition plans that allow those activities to prevent re-establishment to be funded, I think we're in reasonable situations there. If we go over, but in the Greater Mekong, we've of course got conflict that is threatening. It has already created problems in Thailand along the Thai-Myanmar border, where Thailand was very close to being able to eliminate, but it's got re-establishment of malaria. And the other countries in the Greater Mekong are worried about that. So we already have that disruption before we had any of these other changes that we're experiencing now. If we go to, say, the African continent, again, malaria in Africa is quite different in different places. So if we start, say, down in southern Africa, again, they've been slowly shrinking the map, as people used to say, and you've got increasing numbers of places that have eliminated malaria, but it can re-establish if you don't keep pushing that line, pushing the front line further away. We have got problems there with resistance to insecticides. There's a little bit of investment happening for new human health insecticides, but not a lot. It's not a priority. It's a very small part of the insecticide market. But there are a few who are trying to invest in it, but it's quite to try to get those to be accepted to be interventions that can then be funded. That takes a bit of time. And then we have got the introduction of drug-resistant malaria. We couldn't stop it from getting there. It's there. It's in parts of Africa. And again, they're trying to look at what have we been doing in the Greater Mekong. Should they do similar initiatives in the parts of Africa that now have got drug-resistant malaria? And can we focused regional approach to that? But with some of the funding challenges we're having for Global Fund, again, even before some of these other disruptions to the global health architecture, we've not been getting the amount of money that Global Fund wants. So things like regional initiatives end up being on a lower priority. They're often funded with sort of a discretionary amount of funding, whereas country programs get the lion's share, and they should. So there is a concern that even though we've got this situation now happening in Africa, in parts of Africa, that we may not be able to do some of the similar initiatives unless other funding sources come up, both domestic, philanthropy, maybe corporate social responsibility out of the private sector, and hopefully other donors picking up some of the global funding. We also need to still have people looking at the evidence and helping support those guidelines, and the cuts to the World Health Organization, what it's going through, actually also undermine some of that, because we need those guidelines. We need people to look at the evidence, and many of the donors rely upon it being approved through that evidentiary process for them to be able to finance it. There's parts, other parts of the world that are pushing on and getting closer to elimination. But COVID created a little bit of a hiccup in places, but some of what's happening now has really put a lot of us in a spin to know where we're going to go with all of this. And we know once you take the foot off the accelerator, resurgence occurs. That's been well documented, and that's what we're very concerned about. And all the gains we've made, not just in malaria, but in maternal and child health, infant mortality. Malaria was one of the major causes of that in some countries that are close to elimination, still is in many countries. That will just go through the roof again. So any gains we made under the MDGs, to date in maternal and child mortality, are also jeopardised by this, and all that investment people have made is going to be jeopardised. And I think there's some of the messages we need to get across. It's not just about malaria, it's about the health gains, the overall health gains we've made, and the loss of that investment if we don't keep going to the end game of malaria elimination.
Okay, now we are seeing, of course, AMR is one of the top 10 global health crisis which is happening, and it is impacting human health, animal health, and also I think food sovereignty, food security. And we see its impact on malaria as very, very sort of evidence. So you have listed some of the funding problems which are there. What are the other challenges which are preventing us from finding I would say finding all malaria, and then treating all malaria and preventing all malaria?
So, I mean, part of the problem is finding everybody. So it's a data issue, not just for malaria, but it's a data issue across many health issues. So that's part of the problem. Often our health systems are not designed to work at community time or very expensive. So that's why we have to bring in volunteers, CSOs, etc., who can work out of a 9 to 5 government working hours. All of us, I mean, we're here in India, are very diverse language, cultures, etc., geographies. All of that has to be managed, and several speakers here at the World Health Summit, government speakers as well as others, have talked about the real need for proper decentralisation, and with that financial and resource devolution, so that local solutions for local problems. But then that also requires an educated, decentralised management and health workforce, because other countries that have done this, when we looked at it, say, for family planning or maternal health, if they deprioritise that as an issue, then there's no funding going to it. And that's the real challenge we have with malaria, is malaria stops, which is good that it stops killing people, or we're getting close to elimination. Many local authorities may not see that they need to worry about, or if I've got a problem in my backyard, then why should I worry? But the reimportation. So we actually also need to help make a lot of our health managers, our local authorities, not just health authorities, aware about these issues of how diseases cross even district borders or local government borders, and why we need to actually keep investing. But also I think we have to be a lot smarter now. Many in the global civil society community are now saying we need to get more health with the money we do have. So yes, we need more money, but how can we do what we're doing better? So these issues, AMR, a lot of the drivers of that are what we've also been through as the drivers for anti-malarial resistance. So why don't we bring those efforts together? Do we need all of these different can we map out what's the value add of all of these different global health architecture organisations and what their unique niche is and how they can work more synergistically with others? So even at that global health level, we find ways for that to be more efficient so that there's more money going into the health services. And then definitely we need to look at a more integrated approach to doing this work. And that's also where I think that One Health area comes into. We already have people, maybe some of these remote populations are forest goers, but we have forest workers there, or we have wildlife conservation officers. Why aren't we bringing those services together, the resources they have with the resources we need, and doing things jointly? A lot of these, there might already be people working from a community development point of view. Well, then we can add some malaria activities onto their work, or have them advise us better about how to use the right language, the right paradigms, etc. So One Health is not just about looking at zoonotic diseases or food security or AMR. It's also saying how can we work cross-sectorally to get more of everything, more for human health, more for animal health, more for the planet's health, if we actually bring those resources together.
And how is climate change impacting malaria prevention and the spread of malaria?
Yeah, again, it's going to depend where you are globally. So some of the estimates, so for the greater Mekong sub-region, getting hotter, the parasite's not going to like that. But it may mean that it goes to areas at higher altitudes or cooler climates. But dengue is going to become a big problem. In other parts, it's actually going to, it's going to help spread malaria. Because you've got to think about the vector, you've got to think about the parasite, you've got to think about the things that eat the vector, and you've got to think about the human behaviour and response to those climate changes. And it may even, some of the mosquitoes that in many areas were the primary vector for malaria, that may change. And so our strategies may have to change. In Pakistan, after the floods, we saw with all of the water that was around, they got huge upswings in malaria. But it may have been, it may be that it ends up being a different mosquito from the one that we have other strategies for. So we have to be clever, and again, we have to work with the meteorology people, the climate people, to understand what do they see as being predictive changes so that we can make sure that we're up to date and our pipeline of activities, of human resources, of the knowledge we have, and working with communities fits what those predictions are going to be. And we really need to start thinking about that more. Yeah.
What about malaria vaccine? How well is it working in our region? And Africa, of course, we started with Africa, but in our region and in the greater Mekong sub-region. So
the vaccine that's been developed may not suit near elimination settings. It's been really developed, and it's doing reasonably well as a package of public health interventions to actually reduce morbidity and mortality, and also help reduce some of the infant and child malaria. So it was designed for a particular purpose. Whether it's going to be of use whole-wide in some countries in our region, Southern Asia, Southeast Asia, the Pacific, is not certain. In Papua New Guinea, it may, because Papua New Guinea is, in our region, the highest prevalence. Not the numbers. I mean, India still, because of the size of India, you've still got more people, but not percentage-wise of that population. But there it still can be a maternal and child health issue in Papua New Guinea. So in some populations there it may work. But as a strategy, it may not. And is that where, so in our region, is that where we should be investing? Or should it be trying to really get the drugs and diagnostics and personal protection we have out to where the people are? Make sure, work with them to make sure it's delivered in a way that they will accept, they can access, make sure it reaches men, women, people with disabilities, older persons, ethnic minorities, whatever. We just need, with the tools we've got, we've just got to get them to where people are.
Yes, yes.
And we can only do that with the people.
Yes. Any new malaria vaccine in the pipeline or in development?
There's quite a few, but most of them, because most of the malaria is in Africa, most of them are being designed for some of those settings, really, I think in near elimination or pre-elimination setting, it's really looking at, maybe tweaking some of the drugs, particularly around Plasmodium vivax, getting some better diagnostics for that. Of course, one of the other issues, although it's not known to be human-to-human transmission, is zoonotic malaria, or some people call it monkey malaria. And so it may have always been a bit there, but as we're getting better and better diagnostic tools like PCR, we're actually finding some of that. But there may also, with climate change, but also change of land use, human settlements invading areas where monkeys are, we may be getting more of it than we had before. And for many community people, they don't know if it's Vivax or Malaria or Avali, or they just know it's malaria. And if they're told it's eliminated, but they get malaria symptoms, then they may not go for treatment, because the treatments are quite similar. So it could end up becoming a diagnostic issue for communities and not seeking care because, well, it can't be malaria, so I won't go. That's a real concern. And so again, we've got to be ahead of the game. It doesn't matter that it's not human to human. From a community perspective, it's a malarial fever I have, but I've been told there's no malaria, so what do I do? Or the providers will say, well, I've been told there's no malaria, so they won't put it in their differential diagnosis, and so people may die. So there's some of those things. So as you get to the end game, as I said at the beginning, it becomes more and more complex.
And as you said, the last mile is the most difficult one.
It is. And it's where we've fallen short in other times when we've tried to eliminate malaria. And the African continent definitely feels that, because we used a lot of funding in the Asian setting, and when those interventions found they didn't work, then we hadn't even really started in Africa. So that's a real concern from an equity point of view too. How do we make sure that it's a global approach and it's everybody's business, even if you've eliminated, even if, as a donor country you don't have it anymore. It's a global issue, and we know it's linked to so many other aspects of development, empowerment, gross domestic product, and even just getting people to trust services so they will utilise services. We all have to see that malaria is everybody's business.
Yes, that is true. That's very true. Now, just to end with you, I would like your message for WHA 78 and anything else you may like to add, Maxine, which would have been, I might have left asking.
My message would be that we need to, even if it's hard, even if it's difficult, even if it's not popular, we need to keep remaining inclusive and equitable in our approaches. We need to keep a gender equity, social inclusiveness, disability lens, because everybody, if we focus on health equity, it's good for everybody's health. And that message it's going to be a hard road. we'd only just started to get some progress on that, but we have to keep focused on that. And it's really been great for me here at this regional meeting that those words have not been cancelled, that people are saying those words because it makes sense. The data is there. We need to do that, and we have to keep on that message.
Okay. Thank you very much.
My
Thank
pleasure.
you, Maxine.
Thank
you
you.
for being with us.